Perfect. Thank you.
Thank you.
We have no disclosures today. Heart disease is the leading cause of mortality in the United States and costs more than $200 billion annually. While 6.3% of Americans have coronary artery disease, obese individuals have even higher rates of coronary artery disease and coronary-related mortality. Bariatric surgery has been shown to lead to durable weight loss and improvements in obesity-related cardiac risk factors, including hypertension, hyperlipidemia, and diabetes. Until recently, there were very limited data on the impact of bariatric surgery on long-term macrovascular outcomes. 3 recent studies showed substantial reductions in the long-term risk of myocardial infarction and stroke for obese patients with diabetes. In contrast, a recent study that included both patients with diabetes and patients without diabetes demonstrated a reduction in cardiac risk factors following gastric bypass, but no reduction in the rate of myocardial infarction. While the reduction in coronary artery disease following bariatric surgery is now well established for patients with diabetes, the cardiovascular benefits for obese patients without diabetes are less clear. The aims of this study were to evaluate the long-term effects of bariatric surgery and bariatric surgery on the incidence of coronary artery disease and coronary artery disease-associated healthcare utilization for both patients with and without diabetes. We hypothesized that bariatric surgery would lead to a decreased risk of myocardial infarction and reduced rates of coronary revascularization procedures regardless of diabetes status. All adults who underwent bariatric surgery at the University of Virginia between 1985 and 2015 were identified using an institutional clinical database. An institutional clinical data repository was then used to identify a cohort of morbidly obese patients who received care at UVA but did not undergo bariatric surgery. Patient demographics, including age, sex, primary payer status, BMI, obesity-related comorbidities, and prior coronary interventions were captured for all patients through the clinical data repository. Baseline characteristics were collected at the time of the preoperative appointment for surgical patients. For non-surgical patients, these data were collected at the first interaction with our health system in which the patient had a diagnosis of morbid obesity. Propensity-matched groups were then generated to enable adjusted comparisons. Patients were propensity score matched 1-to-1 between surgery and non-surgery groups. All model variables were chosen a priori and included baseline demographics, cardiac risk factors, history of myocardial infarction, history of coronary interventions, and follow-up time. Outcomes of interest were the long-term incidence of myocardial infarction, as well as rates of coronary catheterization, percutaneous coronary intervention, and coronary artery bypass grafting. Univariate analyses of baseline characteristics and outcomes were performed with chi-square test for categorical variables and the Mann-Whitney U test for continuous variables. A total of 3,410 patients underwent bariatric surgery at UVA during the study period. Query of the clinical data repository identified 45,750 patients diagnosed with morbid obesity during the study period who did not undergo bariatric surgery. The 2 groups were significantly different in every baseline characteristic examined, as shown in orange. Propensity score matching resulted in a cohort of 3,242 patients who underwent bariatric surgery and a control cohort of 3,242 patients who did not undergo surgery, and these groups were well matched and well balanced as shown in blue. After propensity matching, there were no statistical differences in baseline demographics, comorbidities, or cardiac history between the 2 groups, with the exception of a slightly higher BMI in the surgery group, as shown here. Patients who underwent bariatric surgery had a significantly lower incidence of myocardial infarction with a relative risk of 0.18, as well as lower rates of coronary catheterization, PCI, and CABG during the study period. Median follow-up was 6.1 years for the surgical cohort and 8.1 years for the non-surgical cohort, though mean follow-up times were 7.9 and 8.0 years, respectively. Subgroup analyses examining patients with diabetes and patients without diabetes were then performed. Bariatric surgery had clear beneficial effects on all outcomes of interest for both groups. Of note, obese patients with diabetes had higher absolute rates of all the examined coronary-related outcomes, as well as greater relative risk reduction following bariatric surgery. Both obesity and coronary artery disease impose a large economic burden on the healthcare system, totaling hundreds of billions of dollars each year. Bariatric surgery has been shown to be a cost-effective treatment for obesity in the long term. In the present study, we demonstrated that patients who had bariatric surgery subsequently underwent less than one-fourth the number of coronary revascularization procedures as propensity-matched non-surgical controls. Over the 31-year study period, 67 fewer CABGs were performed in the bariatric surgery population, which translates to a savings of greater than $2.4 million at our institution alone. When added to the savings from fewer coronary catheterizations and percutaneous interventions, the long-term cost-effectiveness of bariatric surgery is even more apparent. Beyond costs, these findings also translate to far fewer patients being subjected to invasive procedures in a population which is an increased risk of developing complications. Though these analyses are limited by the retrospective nature, our bariatric surgery database has been maintained for over 30 years and includes every patient who undergoes bariatric surgery at our institution. While this is a single institution study, we have a large socioeconomically and racially diverse catchment area. Lastly, our clinical data repository only captures diagnoses and treatments that occur at our institution or are reported at a clinic visit within our health system. Though this could potentially lead to bias, resulting in higher detected rates of coronary artery disease and cardiac procedures for non-surgical patients, we think this is unlikely given the fact that the surgical patients, the bariatric surgical patients, have prescribed annual follow-ups in our bariatric surgery clinic and very frequently see other specialists within our health system. In conclusion, bariatric surgery was associated with a significant reduction in the incidence of myocardial infarction, as well as lower rates of coronary revascularization in a propensity-matched cohort of morbidly obese patients. These findings support the increased utilization of bariatric surgery for the prevention of heart disease. I'd be happy to take any questions.